ma'am.
What is the age? 47?
41 years old, ma'am.
Ah.
Para to life 2, a homemaker who has studied till class 12, who's hailing from Parktown and who's married and belonging to the lower socio-economic class. Presented with the chief complaints of heavy menstrual flow for the past 5 months, pain in the abdomen during menstruation for past 5 months, mass in the abdomen for past 3 months. History of presenting illness. The patient was apparently normal 5 months back. She developed heavy menstrual bleeding during her cyclical menses, which lasted for 7 to 8 days during her 30-day regular cycle. She used to change 6 fully soaked pads per day, compared to which previously she was using 2 to 3 pads per day. She complains of waking up in the night to change the pad. She also complains of passing clots. She complains of pain in the lower abdomen for the past 5 months during the menstruation. The pain starts simultaneously with the menstruation and subsides by the second day of menstruation. The pain is of dull aching type and not radiating. History of mass felt in the lower abdomen since past 3 months, insidious in onset, progressive in nature, and has attained the present size. No history of intermenstrual bleeding, no history of pain during intercourse or post-coital bleeding, no history of discharge PV, no history of fever, no history of epistaxis, gum bleeding, bruises, no history of preceding amenorrhea, no history of difficulty in micturition, urine retention, or increased frequency in micturition, no history of difficulty in passing stools, no history of abdominal distension, no history of varicose veins, no history of pedal edema, no history of loss of weight or unintentional loss of appetite or unintentional weight loss. Menstrual history.
Wait.
Yes, ma'am.
Let us go to the history. So, in history of presenting illness,
yes, ma'am.
Now it is history, not a complaint. So, yes, you have to say that she'll not complain of passage of clots. Only you will be eliciting the history. So, history of passing clots is there. You have to say like that only. You cannot say that she complains. She complains of passing clots. Okay. And the statement as waking up in the night to change pad, those are all unnecessary. Those are all unnecessary. Only relevant things you have to say. Yes, how many pads is soaked per day is very relevant. That you have to say. And and you didn't say, you talk about the mass abdomen in your complaint. Did you say that?
Yes, ma'am.
Okay. Go ahead.
Yes, ma'am. Menstrual history. The patient attained menarche at the age of 13 years. Past cycles, 30-day cycles, 4 to 5 days of flow, 2 to 3 pads per day were used. No history of dysmenorrhea or passage of clots. Present cycle, 30-day cycle, 7 to 8 days of flow, 5 to 6 pads per day. History of dysmenorrhea and passage of clots is there. Last menstrual period was on 20th of July 2021.
Okay.
Obstetric history, para to life 2. A full term vaginal, the first child was a full term vaginal delivery, male child, born 15 years back. The other child, second child, was born full term vaginal delivery, a female child, born 10 years back. Contraceptive history, no history of any contraception use. Past history, not a known case of diabetes mellitus, hypertension, epilepsy, asthma, TB, thyroid disorders. No history of coagulation disorders. No history of hospitalization or surgeries in the past. No history of blood transfusion in the past. No history of any drug intake. Family history, no history of similar complaints in any family members, that is mother or sisters. No history of any bleeding disorders. No history of malignancies in the family. Personal history, she consumes a mixed diet, adequate in protein and calories, appetite normal, sleep undisturbed, bowel and bladder normal, no history of any ill habits.
Okay, go back to your family history.
Family,
Go
ma'am.
back to your family history.
Yes, ma'am.
Okay. Yeah. Why do you want to ask for any bleeding disorders?
In any case of abnormal uterine bleeding, we need to rule out the presence of any coagulation or bleeding disorders in the patient.
When will it present? At what age will it usually present?
Hereditary bleeding disorders are tend to present in the age of puberty, ma'am,
Ah.
or even before that.
Hmm.
And
But
reproductive age females, they can have acquired causes, ma'am, like immune thrombocytopenic purpura, or in the later stages, any blood leukemias can present as abnormal bleeding tendency.
okay. That is only acquired.
Yes,
But
ma'am.
how does the bleeding disorder in the family relevant to your patient? She is 41 years, not
Yes,
an
ma'am.
adolescent age. Only in adolescent age group you have to say. Not in
Okay.
see, whenever you are presenting a case, you have to say what is relevant to your case only. நான் எல்லாத்தையும் சொல்லிடுவேன், நீ எடுக்கிறதை எடுத்துக்கோ. It is not that case. You have
Okay.
to present points only which is relevant to your particular case. Okay?
Okay.
So they
Okay.
say, okay. Okay, go ahead.
General examination.
Hmm.
Consent was obtained and the patient was examined. The patient is conscious, oriented to time, place, and person, and is comfortable at rest, moderately built and moderately nourished. Weight
These
58.
two lines are not needed.
Okay, ma'am.
Only a gynec patient, especially, will be given only when they are conscious. And
Okay.
consciousness, orientation, those things are all not required for a gynec case. The same
Okay.
thing, only it is implied that you have got the consent and have examined. You need not say it. Okay?
Okay, ma'am.
You can
Okay.
directly go to the build of the patient.
Okay, ma'am. So the patient was moderately built and moderately nourished. Weight 58 kg, height 161 centimeters, BMI 22.37.
Okay.
Mild pallor is present. No icterus, no cyanosis, no clubbing, no generalized lymphadenopathy, no pedal edema. Thyroid appears central and normal. Breast appears normal on both sides. Spine appears normal.
Able to see the thyroid?
Not visible. It was not enlarged, ma'am.
Then how do you say as central?
When she swallows, we can see the movement, ma'am.
What movement you will be seeing? Will you see the thyroid? Only if it is enlarged, you will be able to see the thyroid gland. Otherwise, only your the bones only will be
larynx will be seen. Yes, ma'am.
You will not be able to see any thyroid. So, thyroid is normal. That's all. That's all you can comment. Okay? You cannot say that it is appearing central.
Okay.
Only when there is enlargement, you can comment on it. Okay.
Vitals, pulse rate 72 beats per minute, blood pressure 118/78 mmHg, respiratory rate 18 breaths per minute, temperature afebrile. Systemic examination, cardiovascular examination, S1, S2 sounds heard, no murmurs, respiratory system, normal vesicular breath sound, bilateral equal air entry, central nervous system, no focal neurological deficits. Examination of the abdomen, inspection, abdomen is distended, umbilicus is central and inverted, corresponding quadrants move, all corresponding quadrants move equally with respiration, no scars, no sinuses or dilated veins or visible pulsation seen over the abdomen, hernial orifices are intact.
Is the abdomen uniformly enlarged or is it focally enlarged?
Ma'am, in the lower half it was enlarged, that is around the up till the umbilicus it was distended.
Then you have to say specify that the lower abdomen is distended. When you say say as abdomen is distended, then we expect we think that it is uniformly distended, and if it is going to be uniformly distended, then the umbilicus will not be inverted.
Inverted.
It will be
Okay.
either flush with surface or everted.
Okay.
Okay, so you have to specify that also. Okay.
Palpation, no local rise in temperature, no tenderness, a mass occupying the hypogastrum extending into the umbilical area corresponding to 20 weeks of gravid uterus size is felt, firm in consistency, well-defined upper and lateral borders, lower border is not felt, surface is irregular, mobility is felt from side to side.
Here again, the no local rise in temperature. All those things you have to first describe the mass only. If there is a
Okay.
mass, you have to describe the mass and then say that it is not warm.
Okay, ma'am.
You cannot say as local rise of temperature. The terminologies are also very important.
Okay.
It is not not warm, not tender.
Okay.
Like that only you have to say. You have to talk.
Okay.
Where will you elicit the tenderness then? You will be eliciting only when there is a mass.
Mass. Yes.
When there is a mass, you will be eliciting tenderness over the mass. If there is no mass, then you can elicit tenderness anywhere in the abdomen. Okay? Yeah.
Okay. Percussion, a dull note is heard over the mass, no fluid thrill is elicited. Auscultation, bubble sounds are heard, no audible bruise. Gynecological examination, external genitalia are normal. Bimanual pelvic examination not done, it is to be actually to be done.
Okay.
Summary, a 41-year-old Mrs. Priya presents with prolonged heavy menstrual bleeding and dysmenorrhea since 5 months and mass in the lower abdomen since 3 months. On examination, a firm, non-tender mass of 20 weeks gravid uterus size in the midline, mobile from side to side, can be palpated. Provisional diagnosis, a case of mass per abdomen, probably fibroid uterus, associated with abnormal uterine bleeding, AUBL.
When you give the diagnosis, this is not the way, ma. You have to start from the age. Then for any gynec case, first you have to say the age. So 41-year-old female, and then about the menstruation. Menstruating, that is she is whether she is menstruating or postmenopausal. So 41-year-old female menstruating, and then about the parity. She is para 2, live 2, is it not?
Yes, ma'am.
Then you have to say as multiparous.
Okay, ma'am.
With fibroid uterus. AUBL. That must be your diagnosis. You cannot say as a case of mass per abdomen probably fibroid. You have the diagnosis should include the age, about the menstruation, about the parity, and you have to directly come off to the diagnosis. And then if there are any comorbids, you can include the comorbids like hypertension, diabetes. Okay?
Okay.
Yeah. How will you proceed?
Ma'am, basic general investigation.
I don't have any slides for this. You have to. Okay. You keep telling. How will you proceed?
Okay. Since mild pallor was found during the examination, first we can take the hemoglobin level of the patient, ma'am. Then complete blood count and differential count is taken. Then bleeding time and clotting time are checked.
Pelvic bimanual, bimanual pelvic examination has to be done. That has to be done to confirm your diagnosis. Most of the time, by doing a bimanual pelvic examination itself, you can come nearer to your diagnosis. And then only you have to go for other blood investigations. Whenever an examiner asks you, you have to say that. Okay, go ahead.
Then coagulation profile of prothrombin time and APTT and thyroid function test needs to be done.
Then here again, why do you want to do a BTCT, PT, APTT? All these are very costly. You have to do what is relevant for your patient. Okay? PT, APTT, it should be done only in adolescent age group, or when there is a bleeding disorder or history suggestive of bleeding or coagulation disorder. Otherwise, you cannot say all those. And, okay.
Then for imaging studies, a trans-abdominal ultrasound can be done and trans-vaginal ultrasound can be done. Doppler, a pap smear, and endometrial biopsy should be done.
What do you want to do, trans-abdominal or trans-vaginal?
Ma'am, since this is 20 weeks gravid uterus size, the number of fibroids and the consistency can be better appreciated through a trans-abdominal ultrasound.
Okay, then stick on to that. Why do you want to include trans-vaginal also?
Okay.
Okay. Then what for
Doppler should be to know the vascularity of the tumor. In the case of the fibroid, the vascularity is present in the periphery, ma'am. And in case of an adenomyosis, the entire diffuse vascularity can be seen appreciated through Doppler.
Only for that sake you want to do a Doppler. Doppler is not needed for a case of fibroid. And just an abdominal ultrasound will do. Okay. Then
pap smear, because she's to rule out cervical cancer, ma'am. Because she's
pap smear is for routine screening.
And endometrial biopsy to rule out any endometrial cancer, which may be
what are all the indications for endometrial biopsy?
And perimenopausal women who has abnormal uterine bleeding, generally we do a endometrial biopsy.
Okay. Then what is the difference between endometrial biopsy and fractional curettage?
Ma'am, an endometrial biopsy, it can be done through either DNC can be done and that specimen can be used for biopsy. In fractional curettage, we take specific, in some specific locations, we take the sampling, ma'am, to check for, no, I didn't get you.
How do you do that?
Using a hysteroscope, ma'am. Hysteroscope, the specimens are collected specifically from the fundus, from the endocervix.
Of fractional curettage?
We insert the hysteroscope and we take the specimen first from the endocervix, then separately from the uterus, no?
Steps. There are 5 steps. Directly you take curette from the endocervix and then directly you go on into the uterus. Okay. See, there is a difference between endometrial. By saying as endometrial biopsy, we mean to say that it is an OP procedure. Okay. And a fractional curettage, it is an inpatient procedure. Patient should get admitted and it is done under anesthesia. There is an endometrial biopsy. We don't need any anesthesia. It can be done in the OP setting itself. And we use either a disposable pipple cannula,
for
endometrial biopsy cannula for taking this endometrial biopsy, in which we introduce that cannula. It will be too thin. The cervical dilatation is the most painful part, and patient will might even go for shock. But the endometrial biopsy cannula, this pipple will be too small, which does not require an the cervical dilatation. So we introduce it inside the uterus and take a biopsy, and it's a blind procedure only. We take a biopsy. And it will be only a small bit of tissue. Whereas in fractional curettage, we do all pre-op investigations and it is done either the IV anesthesia or paracervical block. By saying as paracervical block, we inject local anesthetic to the sides of the cervix, and we anesthetize the plexus over there, and then we do a speculum examination first to see the cervix, and then we do go and do a bimanual pelvic examination. Because patient is under anesthesia, the examination, the assessment will be accurate. You'll be able to examine the patient properly. You can assess the size of the uterus, the position, direction of the uterus, whether there are any adnexal marks. Everything can be assessed, and you can take this as an opportunity. And then you catch hold of the anterior lip of cervix with a valsellum, and then take endometrial curetting. First, you have to take endometrial curetting, and if there are any curettings, you have to keep it aside safely, because it has to be sent separately for histopathological examination. Then you introduce the sound, uterine sound, to see the uterocervical length. The uterine sound is an instrument which which has measurements either in centimeters or in inches. So what is the normal length of the uterus? Uterocervical length, UCL. Normal length.
5
centimeters. I'm asking about uterocervical length. Include the cervix also. It is 7
centimeters.
Around 7 centimeters or 3.5 to 4 inches. So you have to measure that. In your case, it is a 20 weeks fibroid. Then definitely the uterine cavity length will be larger.
More.
Is it not?
Yes. Yes, ma'am.
When it will be larger? If it is going to be mucus fibroid. If it is going to be subserous or pedunculated, definitely the uterine cavity length will be normal only.
Okay, ma'am.
Okay. Yeah. So first assess the uterocervical length, and then you dilate the cervix. Without dilating the cervix, you cannot take biopsies from all the walls. And you dilate the cervix. What is the instrument you will be using for dilating the cervix in a gynae case? What are all the types of dilators, cervical dilators available? One is Hegar's dilator, and the other is Matthew Duncan. Matthew Duncan. The Hegar's dilators, it will be about hands width, length, and both the ends can be used for dilatation of the cervix. Whereas in Matthew Duncan, only one end will be used for dilatation of the cervix, and it will be acutely curved. So Hegar's is used in obstetric cases where the uterus itself will be very soft. In cases of MTP or in any other obstetric procedures, they use Hegar's dilators. It will be smooth, and it will to avoid perforation. Whereas Matthew Duncan you use in gynae cases where the uterus is firm. Okay. And you dilate the cervix up to, and the dilators will have graded measurements. So you dilate up to 14 Matthew Duncan. And after dilating, you take, with the help of uterine curette, you take curettings from anterior wall, posterior wall, lateral wall, fundus, and also the isthmus. Previously, we used to send each and every sample separately for histopathological examination, but nowadays we don't send it separately. We take all the curettings of the entire uterine cavity as one sample, and the endocervical canal sample as another sample. So we are sending only 2 samples, because whether if there is going to be any carcinoma, whether it is in the anterior wall or posterior wall, does not going to alter your management part. It is one and the same. But If there is any extension into the cervical canal, then the management totally differs. So that is why we want to, even before inserting an uterine to measure the uterine sound, to measure the uterocervical length, we are taking a curating from the endocervical canal and then go for dilatation of the uterus, because we don't want any contamination of the specimen from the uterus to the endocervical canal. We want it separately. So we take two separate samples. This is what is called as fractional curettage. And the gold standard for diagnosis is hysteroscopy guided fractional curettage, where you take an endocervical sample and then dilate the cervix. After dilating, you introduce a hysteroscope to do a diagnostic hysteroscopy. In diagnostic hysteroscopy, you can use saline as distension medium. So in this, you can inspect the cervical canal and also all the walls of the uterus. Because most of the time, an endometrial carcinoma starts focally. And fractional curettage, if you are going to do it blindly, you might miss that focal point and the samples might not be representative of the area which we need. If you are going to do a hysteroscope, you can see if there are any changes. If you notice any focal changes, you can take a biopsy from that particular point so that it will be a representative. So the gold standard is hysteroscopy with fractional curettage. But these are all indicated. This fractional curettage is done. Endometrial biopsy can be done whenever. It should not be, actually, there is no need for endometrial biopsy in adolescent age group and in reproductive age group. When all will you do? Fractional curettage is done only in perimenopausal and postmenopausal women. When do you need an endometrial biopsy? Or if the same procedure is done in reproductive age group, we call that as dilatation and curettage. When do you want an endometrial biopsy in reproductive age group? What is the indication for this? What is the indication for doing an endometrial biopsy in reproductive age group? Your patient is in reproductive age group only. Only after 44, you can say as perimenopausal and postmenopausal. What is the average age of menopause? Anyone else? It is not necessary that Kavya alone should answer. Anyone can answer? What is the average age of menopause?
45 to 50.
Around 47.5. Okay. So your perimenopause is only after 44. So your patient is only 41. Then what is the indication for endometrial biopsy?
Endometrial ultrasound.
No, endometrial tuberculosis, you have to rule it out as a last resort only. That is not that common. And
ultrasound thickness of the endometrium.
Yes, you have to see the thickness of the endometrium. So, normal thickness of endometrium in reproductive age group. What is the normal thickness?
Reproductive age group will be during the secretory phase. It can be up to 12 mm.
Up to 12 mm. Up to 12 mm is normal. When it is more than 12 mm, or if there is any irregularity in the endometrial thickening, or if you notice any polypoid growth in the endometrium during ultrasound, then it is an indication for endometrial biopsy. Otherwise, for reproductive age group or adolescent age group, you don't need, there is no need for an endometrial biopsy at all. So, what are all the things you will see in an ultrasound?
In an ultrasound, first you'll confirm the diagnosis, ma'am. Then you see the number of polyps that are present, number of fibroids that are present, ma'am. Then we can to a certain extent differentiate between submucous fibroid and intramural fibroid, the position of the fibroid relation to the wall of the uterus, ma'am.
Your provisional diagnosis is fibroid. Sometimes a midline mass. It might be an ovarian also. So in your ultrasound, you have to see whether the mass is arising from the uterus, ovaries, or it can be a mesenteric cyst also. So you have to see where the mass is arising from and whether it is a fibroid, and then what else will you see?
The number of the fibroids can be seen, ma'am.
Okay.
Any calcification or cystic degenerations that are taking place in the fibroids can be seen.
Okay.
Or whether it is a true, if it is a broad ligament fibroid, we can differentiate whether it's a true broad ligament fibroid or pseudo broad ligament fibroid.
Okay.
Then we can see for pressure effects if there is a compression on the bladder, ma'am, or on the ureters.
How do you see that? You have to look for residual urine.
Residual urine on the
you have to ask the patient to empty the bladder and see whether the residual urine volume is normal or not. Okay, then
we can
endometrial
thickness. Endometrial thickness.
From endometrium, you have to go outside to the serosa and then to the adnexa, everything. So endometrium, thickness, irregularity, and any polypoid growth. And in the myometrium, whether it is a fibroid or anything else, adenomyosis. And then to the serosa, and then any adnexal masses. And then you have to see the ovaries also, whether it is normal or any other mass arising from the ovaries. Okay, that completes your ultrasound examination. And then you have to look for liver also, liver, spleen, and any presence of any free fluid in abdomen, ascites. Sometimes abdomen is the Pandora box. When you open, after doing all these investigations, when you go with the provisional diagnosis of fibroid uterus, you might end up in an ovarian mass. So you have to see everything, including liver, spleen, ascites, everything. Okay.
Okay.
Yeah. Okay. So endometrial biopsy is only in indicated patients in reproductive age group. Okay, ma. Okay. Then proceed. How will you proceed?
Then for treatment, first you have to correct the anemia of the patient, ma'am. Then since this patient is completed her family and is 41 years old, for permanent cure, we can go towards hysterectomy for the patient, ma'am. Because the size of the uterus is also 20.
So what? Why can't you plan for a myomectomy? Now only we discussed average age of menopause is 47.5.
47, yes, ma'am.
If you are going to do a hysterectomy, then you are going to give her a premature menopause. Even if you are going to leave the ovaries also, the ovaries will be functioning only for 2 to 3 years.
Yes, ma'am.
But the advantages of having an ovarian function is very high. Is it not?
Okay. Yes, ma'am.
What are all the advantages? It is cardioprotective.
Cardioprotective, prevent osteoporosis. Yes, ma'am.
Yeah, all those are very huge advantages. So you cannot just like that. She has completed her family, but 41 is not too big an age. You have to plan for a myomectomy only, and even 20 weeks fibroid is not an issue. You can plan. But what are the disadvantages of myomectomy?
Additions for me, heavy bleeding can be there, ma'am, during the procedure of myomectomy. Then additions can be formed.
Okay.
Then
recurrence, because you are preserving the uterus, sub-centimeter fibroids can grow in size, and there can be recurrence of fibroids. and you might need one more surgery at a later date.
Later
That
stage.
is the disadvantage, but the advantage is more when compared to the disadvantage. So you try to preserve the uterus as much as possible in a 40 reproductive age group. Okay. If she is going to be in perimenopausal age group, then you can plan for a hysterectomy.
Hysterectomy. Okay.
Okay. What are all the types of myomectomy available?
You can do either a vaginal myomectomy or hysteroscopic myomectomy or abdominal through an incision in the abdomen. Abdominal myomectomy can be done.
Okay, laparotomy and
Laparotomy
myomectomy.
and myomectomy can be done.
Can you do it in laparoscope? Laparoscopic myomectomy? It can be done, but only thing is the morcellator, usage of morcellator.
Morcellator can lead to, if it is a cancerous, it can lead to disseminated cancer.
Even if it is not going to be a cancer also, we encounter a condition called peritoneal leiomyomatosis. So nowadays it is not being done. If at all, if we want to do, we morcellate in an endo bag. But generally that is not recommended, that is not approved. So either a vaginal or hysteroscopic or an open myomectomy. Okay. Okay. So vaginal myomectomy is done for
smaller
any
size
vaginal polyps, a submucous fibroid which is pushed down into the uterine cavity and protruding, if it is a pedunculated one, protruding through the cervix, then you can do it vaginally. Just clamp the pedicle, put a ligature and cut off the fibroid. That's all. That is called as vaginal myomectomy. In hysteroscopic, if you are going to plan for a myomectomy, you need one more investigation. What is that? You need an MRI.
MRI because of the only type 1 and 2 can be removed.
What is type 1 and 2?
Which is more than 50% inside the uterine cavity, ma'am.
More than 50% inside the uterine cavity, rather than the myometrium there should be less than 50% of the
in the myometrium.
Fibroid inside the myometrium. Then only you can do a hysteroscopic myomectomy. So in hysteroscopic myomectomy, you have to do an MRI and do fibroid mapping before you plan for a myomectomy. Okay. In open myomectomy, the major complication is, as you said, the bleeding. But you can prevent that using
GnRH and vasopressin intraoperatively.
Vasopressin injection intraoperatively. Yeah. Preoperatively, yes, GnRH can be used. That has to be used only for a short time. And it can be used to reduce the size of the uterus. But what is the purpose, Benly? If you are going to plan for a laparoscopic myomectomy, there is a point in reducing the size of the uterus. Otherwise, you can directly go and remove the uterus, because your usage of GnRH is going to obscure the
capsule of the fibroid.
Yes, there will be difficulty in removing the fibroid easily doing a myomectomy. So instead, you can go for a vasopressin injection intraoperatively over the fibroid, and then you can remove the fibroid. What is the post-operative complication?
It can be recurrence can be there, ma'am. Then infections can be there.
Immediate post-operative. Whenever you are asked about
primary, secondary, and reactionary,
you have to say as immediate complications and delayed and late complications.
Immediate complication is hemorrhage only.
Okay, hemorrhage. Then
trauma to the bladder.
Yeah, that is intraoperative. The main thing is there might be a rise of temperature.
Okay.
Post-operative hyperthermia will be there. So, mostly that will be there for 48 hours. After that, it will subside. It is not. It doesn't denote any infection, but because of myomectomy, there will be a rise of temperature. You should be expecting that, especially when you do huge myomectomies. You can expect rise of temperature in the first or second post-operative up to second post-operative day. Okay. If the same patient is going to be around 45, 46 years, then hysterectomy, as you said, will be the treatment of choice. Okay. Now narrate the steps of abdominal hysterectomy.
First, the patient should be anesthesia according to the choice of the anesthesian, mom. It can.
Why it should be a choice of the anesthetist? Now you know the patient. She is not having any comorbid, not a hypertensive, or
Yes,
she is not taking anything else. She is not even obese.
So general anesthesia.
Why general anesthesia? It's a pelvic surgery. We generally go for regional anesthesia only. Okay. Regional, by saying as regional anesthesia, either it is a spinal anesthesia or
spinal anesthesia or epidural.
Okay, then?
Yes, ma'am. Then we have to, the abdominal incision can be either a suprapubic transverse incision or a vertical incision.
We generally go for SPT incision only because it is only 20 week size. If it is huge, somewhere 30, 34 weeks, then you can prefer a vertical incision. Here it is only 20 week size, so you can go for a suprapubic transverse incision. Okay, then?
Then we have to retract the bladder, mom, to avoid any injury to the bladder, and use packing behind the uterus to prevent damage to the intestines.
Okay.
Then we have to clamp the round ligament, mom, first.
Okay.
And then clamping of uterine blood vessels, mom, should be done close to the lateral wall.
Why? What?
Clamping of uterine blood vessels, mom.
Where do you clamp? Before uterine vessels, you have clamped, cut and ligated the round ligament.
The round ligament. Yes, ma'am.
After that? If you are going to remove the ovaries, where will you place the clamp? If you are going to retain the ovaries, where will you place the clamp?
Ma'am, if you are going to retain the ovaries, you have to place the clamp close to the cornu of the uterus.
So where is it? What is the ligament you are ligating by placing it close to the cornu?
Ovarian ligament, ma'am.
Ovarian ligament, because ovarian ligament is connecting the ovary to the uterus. Yes, the ligament connecting ovary to the lateral pelvic wall is
infundibulopelvic ligament.
Infundibulopelvic ligament. So, when you are going to remove the uterus, you will be placing the clamp over the infundibulopelvic ligament. If you are going to retain the ovaries, you are going to place the clamp over the ovarian ligament.
Yes, ma'am.
Okay. Then after clamping cutting and ligating the infundibulopelvic ligament, if you are going to remove the uterus, remove the ovaries, then you have to come to the utrovesical fold of peritoneum. So you have to cut the UV fold of utrovesical fold of peritoneum, and after that your bladder will be visible. So you have to push the bladder down. Okay. What is the anatomy of the bladder in relation to the uterus?
It is anterior, ma'am.
Yes, anterior till the fundus or till the external os? To what height? you expect the bladder to come?
Till the external loss, ma'am.
External loss? External loss is an
No,
intravaginal portion.
intravaginal. So it's up to the fundus, ma'am.
Fundus, you go and verify the anatomy.
Okay.
Will it come up to the fundus? No, up to the internal os. So, at the level of internal os, you cut open the UV fold of peritoneum and then you push the bladder down, because you are going to do a complete hysterectomy, include the cervix also. So, if you are not going to do this step with caution, you might injure the ureter, especially in bigger masses like 20 weeks fibroid. There are high chances of injuring the ureter. Only when you push the bladder down, what is the relation of the ureter to the uterine vessels?
The right flap.
Uterine artery. What is the relation of the ureters to uterine artery? It crosses the ureter from lateral to medial. At the level of the internal os.
Internal os.
At the level of the internal os. So, if you are not going to put, if by pushing the bladder down, the ureter is displaced away from the uterine artery. So, before putting a clamp over the uterine artery, you have to do this step with caution. Otherwise, you'll definitely injure the ureter while clamping the uterine artery. So, that is why you are doing this step. Okay, after pushing the bladder down comfortably, then you put a clamp over the uterine arteries, cut and ligate the uterine arteries. And then after that,
the Meckenroth ligaments, ma'am.
Meckenroth. Then you put a clamp over the Meckenroth's ligament. Meckenroth's ligament is the triradiate ligament. So it includes uterosacral ligaments also.
Yes.
So you have to include everything and then clamp, cut and ligate the Meckenroth's ligament. After that, the cervix is out. Then you close the wall, check the hemostasis, and then you
close
come out abdominal wall by closing the abdominal wall in layers. So these are all the steps of abdominal hysterectomy. Okay, ma. And then you send the specimen for histopathological examination. Okay. Any doubts? So today you have learned the steps of fractional curettage, how you do a hysteroscopic fractional curettage, the steps of abdominal hysterectomy. Yeah. Any doubts for anyone?
Good morning, ma'am.
Good morning.
Are not fibroids subsiding, ma'am, after menopause? Is it not under the hormonal influence, ma'am?
No, definitely. So in perimenopausal age group, if it is going to be too small, what are the indications for surgical management? Who is it speaking? May I know?
I am Karthik, ma'am.
Karthik, you switch on your video.
Okay, ma'am. Are you able to see, ma'am?
No.
Okay.
Okay. Karthik, what are all the indications for hysterectomy or a surgical management in a asymptomatic fibroids. What are all the indications for hysterectomy, surgical management in an asymptomatic fibroid? Karthik?
If it is very large,
Anyone?
ma'am.
Large means what is the size?
I'm not sure, ma'am.
Greater than 12 weeks.
Yes, greater than?
Greater than 12 weeks.
Any fibroids, even if it is asymptomatic, if it is greater than 12 weeks, then it is an indication for a surgical management. Okay. In perimenopausal age group, if the fibroids are going to be bigger, if it is going to be greater than 12 week size, then we plan for a surgical management. If it is 12 weeks or lesser, after menopause, definitely it is going to shrink in size. Then we plan for a conservative management. That is where the role of medical management comes in. So, till menopause, if the same patient is going to be around 46 or 47 years, then you might expect a menopause in 1 or 2 years. Then you can give her medical management, and if it is less than 12 weeks size, and then wait for menopause, because in menopause it is going to shrink in size, but it will not disappear. Okay.
Okay, ma'am. Thank you, ma'am.
Any other doubts? Yeah. Any other doubts?
Ma'am, after menopause also when we give medical management, it is on, we can give it only.
Yes, ma. Yes, ma.
We are going to give medical management also only for a short period of time now, ma'am. Won't it recur again even after menopause?
No. See, the medical, what are all the types of medical management available? See, you can either give
GnRH.
non-steroidal. No, GnRH alone is not the medical management, ma. You can give symptomatic treatment. You need not aim at reducing the size of fibroid. You can give non-steroidal anti-inflammatory drugs like tranexamic acid. Okay, so that will reduce the, if you are expecting a menopause shortly, then your aim should be at reducing the blood loss. So you can give them a tranexamic acid, a non-steroidal anti-inflammatory drugs, so that during, if it is going to be the heavy menstrual bleeding only, if it is going to be controlled with your, tranexamic acid, then you can pull on with that till her menopause. But if she is bleeding heavily with that, then you can switch over to the other drugs like hormones like progesterones. Even you can insert a Mirena. Progesterone can also be inserted. But only if it is getting controlled, with the bleeding is getting controlled with all your things, and if the uterus is going to be less than 12 week size, then you can plan for your medical management. Otherwise, your GnRH analogs can all be given only for a very short time, only for 6 months. After that, you have to give them add-back therapy with a progesterone. Otherwise, that itself will predispose her to osteoporosis and also a carcinoma. So, GnRH analogs are prescribed only for a short duration, especially when you are trying to buy some time for till you plan your surgery. Some people around that period, they might be having one of their sons or daughters' marriage or some occasions like that. Some might want to postpone the surgery for some 3-4 months. So, till such time, this GnRH analogs can be used to reduce the blood loss and also to shrink the size of the uterus only for a very short period. But whereas your NSAIDs can be used even for up to 1 year also without any complications. If she is going to get her menopause within a short time, then this symptomatic management with medical drugs can be utilized.
Okay. Ma'am, so for reproductive age group also, medical management is only to reduce size if we want to. Otherwise, surgery only is preferred, ma'am.
Yes, ma. That too, especially when it is more than 12 week size. If it is less than 12 week size, if it is going to be asymptomatic, we are not going to do anything for that particular patient in reproductive age group.
Okay. Okay.
If it is sometimes it will be diagnosed incidentally during a master health checkup or during a routine ultrasound for some other ailment, it will be diagnosed. If it is going to be asymptomatic, sub-centimeter fibroids, small fibroids, then we are not going to treat her at all till it grows in size. In reproductive age group and even in other age groups also.
Okay. Thank you.
Anything else? Any other doubts?
No, ma'am.
Okay, ma. Thank you. Thank you.
Thank you, ma'am.